watching Cablevision, Channel 31, local origination programming, your hometown network.
Mind Over Matter, sponsored by the Norfolk Alliance for the Mentally Ill. Today we're going to talk about cultural barriers to treatment. And it's a pleasure to welcome Diane Riva, who is a clinical social worker, and Dr. Jorge Veliz, who's a psychiatrist with many years of experience in this field. Perhaps we could start with you, Dr. Veliz. What are some of the needs of minority groups? And then we'll get to barriers in a moment.
George, thank you very much, first of all, to have invited us to come here. I think some of the things that we will be talking tonight are really interested to us as a persons who have come from a different culture and be able to explore the mental difficulties that a person goes through it, just coming into a different place. So I really welcome the fact that we are here tonight, and thank you very much. I think one of the main issues is the fact that as a person from a different culture, when you are coming in and are exposed to a different set of values in a different culture, you have to amalgamate and try to understand them. And during that process, it takes sometimes years and really to really understand the culture. In a sense, you are kind of giving up some of your own values about your own culture to be able to understand the new values. And during that process, it can happen many different things. Normally, a person will go through this process and will take them years to adapt. If a person has some difficulties that normally would have produced a stress in normal person, going through this process, it will highlight the difficulties that the person is going through. Mm-hmm. So one of the things that it is most important is that a culture that is exposed to a different culture, it produces different tensions among the two of them. And the persons are only as a result of them will produce certain difficulties. And as a persons who do treat the mentally ill, then we have to be familiar, at the same time sensitive to those issues, and that therefore be able to explore them with the difficulties that goes how to deliver that system.
So, for example, if one of my patients was Hispanic, might I encounter some problems that you wouldn't encounter if you were their treator? And if so, what are some of the problems?
I think, Diane, do you feel maybe the best example is to just remember some of our patients that we have seen it. Mm-hmm. A Spanish patient comes in, and what is the first thing that they usually notice once they see you and once they talk to us? What is their response? And then you probably mm-hmm. can have a flavor for it.
Yeah, I agree. I mean, Dr. Veliz and I talk a lot about how I've really noticed that the population that I work with are really receptive, especially the Hispanic population, because they feel some sort of sense of connection with me, because not only am I Hispanic, but I also am able to communicate with them through their language, and I really see a difference. And this past year I had gone to Mexico to practice and improve my Spanish, and it really has helped as I've come back here. I've been able to work in a very different way with a lot of the Hispanic inmates that I wasn't before because of the communication barrier. I think that I've really been able to pick up on, like Dr. Veliz is talking about, a more sensitive position with them and what they're dealing with, and with such a limited number of clinicians that speak the language, how grateful they are, different issues that we can look at because I'm able to communicate with them, how it's not just limited to mental health but also medical. They really reach out to me as well to help them if they're stuck with something that they wouldn't otherwise have been able to do because of the language barrier.
Let me pick up on that. You know, that what she said is probably the most important, the crucial part. A person comes in and, you know, it's exposed to a place. Let's assume, just for the sake of assuming, that there's a person who really doesn't know the language. And that can be said for any other culture. You know, there are so many barriers just to learn that language. But the person is here, nevertheless, for X, Y, and Z reasons. And now the person is exposed to a system that really is so different, so unusual to them. Things that we take it for granted, the person is unable even to accept them, to be able to go beyond that. For example, small things, very small things. Many cultures don't have, let's say, right turn after red stop light. Just don't have it. And, you know, you just happen to be driving, and he said, wait a minute, everybody is going right turn, or everybody is turning, you know, even though it's a red light. How is that possible? So very small things to the major complex areas of, you know, difficulties that the person can express. It is okay to say certain words in certain language, but it's not okay to say the same words in a different language. So you see that small things can make a big difference, and the big things can also even make a major difference on that person. And like Diana said, the first thing that the person goes is and say, can you speak my language? Are we able to communicate? And if the person doesn't know the language, at the moment that he first sees one person who is able to understand, it's like an immediate connection. It's like all of the sudden, the person is able to see the oasis. And I describe it as an oasis because it's really an illusionary fact. It's not that it's true that the person is different because he's talking the same language, but it's true that he's able to communicate in that language and therefore be able to think that the person is able to be better understood by that person. And that is so, it's like really walking through the desert and then all of a sudden be able to see an oasis that you are able to drink water from it, although it may not be real. You know.
All right, but by contrast, for example, Dan, let's say the patient comes to me and I have an interpreter present. Is that not going to work as well?
I think to a degree. I think because it happens a lot where I work, and there seems to be something that gets missed, whether it's, you know, expressions that the interpreter might not be able to articulate to the clinician, or things that they may not feel comfortable talking to an interpreter through another clinician. So I do think that it's affected to a degree, but there, you know, when you're one-on-one with the person, part of that connection is then being able to feel like you get it 100%, that I think gets missed through interpretation.
Well, I'm certainly in agreement. I think it would be better, for example, if I spoke Spanish, if I'm working with a Hispanic patient, but I don't speak Vietnamese, but I said earlier I have a lot of Vietnamese patients, and yeah, I agree with you. Having a third person in the room already begins to skew things, and I've learned a lot about the Vietnamese culture, working with a number of these clients, and one thing, for example, is to make sure they complain to me. You know, there's a real tendency for them, and I think sometimes the interpreter plays to this, to say everything is fine. And I have to keep inviting them to say, I'm glad to hear that, but is everything fine? You don't look like everything is fine. And
you know, let me give you one example now. Let's say that as a kids, you know, we wanted to say something to our parents, but we always have to have the neighbor who come in to tell them our needs. We want the neighbor to tell them, you know, look, I really need this pair of shoes. I think after a while, it really gets very frustrating. And that the person, the kid at that moment, will feel, wait a minute, I need to talk to my parents. I need to be able to communicate. And I think it's just a basic need. I have nothing against the interpreters. All the opposite. I think they have, you know, like fulfill a niche that is so important and so vital in order to make things work. I think the person who is, getting the help has the obligation to learn more of the English. I think the person who is doing the psychotherapy or the clinical intervention has the moral obligation, if you may, to be more sensitive to the language and understanding that if the person is going to communicate to a third person, then some other factors have to be taken account. It's not like the complete trust that the person is going to be able to put, number one. Number two, the translator, if we call it, I prefer to call the interpreter, because they usually interpret what the person is saying. They do not translate, because it's so difficult to translate word by word. As a matter of fact, a lot of persons who have learned the language later on, they're much able to translate and not to interpret it, because word by word, it has a complete different meaning. Just to take an example, in Spanish, we usually say things backward when we translate it. And some of the words, the utterance of the words, it becomes very different. And when it translated into a psychotherapeutic relationship, it becomes difficult to really understand and to have an understanding of it. My experience has been that if you translate or interpret it for somebody, it takes longer to get to know that person. While you do it directly, either in English or in any other language, it becomes easier because the person becomes more at ease about. Doesn't have to go to the neighbor to talk to your parents. And that communication is so vital for us. It is imperative for that person to be able to communicate and believe in the therapist that is he or she talking to.
So in lots of ways, though, you're really talking about the beginning of a sort of a therapeutic rapport. And obviously, if there's a certain connectedness with the language, you're saying people really will begin to feel more comfortable in talking to you about what bothers them.
And being the language, being the language like the first step. The sensitivity to the language, it becomes part of it. And then it becomes the understanding of the cultural values that exist between the two different cultures. There are so many cultural values. So part of a culture that when you are able and sensitive to them, you are able to understand the person better. Each culture has its own cultural values that they are so peculiar to them. Let me give you an example. If a person comes into the room, different cultures, you have to stand up. In other cultures, that is not, something that you normally do it. And it becomes as a matter of respect, as a matter of understanding between two persons. And that's only a set of cultural values. There are hundreds of them that we are not even consciously aware that they exist. But when it comes in the therapeutic arena, all of them had to be put at work and be able to retrieve some of them, be able to be sensitive to them, and then be able to work on them.
Well, I'll tell you what, maybe at the end of the break we can pick up with some of these factors and look more carefully at some of the barriers. So we'll take a break at this point. Thank you.
Wherever you go, you see the signs. A new century is coming, and with it, 1,000 questions. Will there be peace? Will your family ever be in harm's way? Will a small town in Texas be hit with a hurricane? Will your daughter ever need a new kind of blood treatment? Will that nice man who hands you the paper ever need a hand to hold in a time of need? We have no crystal ball for the world that awaits, just one promise. We'll be there, whether it's in the eye of the storm, in your darkest hour, in your time of need, or in the light of day. We'll be there.
Imagine yourself serving in today's Peace Corps.
I wanted adventure. I wanted to go out, learn about a new culture, learn a new language, and bring it back to the United States.
You know for sure for 2 years it's going to be like nothing you've ever experienced. I joined the Peace Corps because I think Peace Corps as a development organization is one of the best in the world.
My dream of becoming a physician, if anything, has become enhanced.
The best part of my experience here, I think, as a volunteer is that I found a second family.
I think one of the best things you can do with your time, it's a great program where you can come and help people out. I'm excited about it.
There's a role for you in Peace Corps. It never really feels like work. You love what you're going through. You're helping people, you're working in the community, and people really appreciate you so much for every little bitty thing that you do.
It's fun.
Make a difference. Join the Peace Corps. It's the toughest job you'll ever love.
Let's talk about, stay on the theme of barriers to care, barriers to treatment. We've clearly identified the language one, although, Diane, you made a comment about how the interpretive services work in some agencies. Maybe you could just pick up on that, and then we could look at some of the other cultural barriers to treatment.
Well, the one I was thinking about is the one that is used through an interpreter over the phone, and so that has the clinician and the patient together in a room with the interpreter on the phone, which, depending on what the patient is dealing with at the time, can make it all the more difficult to.
You said it was a speakerphone.
A speakerphone,
so
yes.
I always feel with a speakerphone I've got to yell. Is that probably not the case?
No, it's not the case, but they tend to get a little suspicious of who exactly is the person on the other end and who am I telling things to via the telephone.
So who do they talk to? Do they talk to the phone, or do they talk to you, or is it shift?
It tends to shift the ground a lot of times too. They don't, I mean, they're coming in not knowing what's going on, and so it makes it really overwhelming for them.
Do you have to pay for that service, or does the telephone company provide that service?
I believe the telephone
company
provides it, yeah.
Okay. I know with my Vietnamese patients I have a live interpreter, and about 4 or 5 years I'm on my third interpreter, and actually I prefer translator to interpreter, because sometimes I have to, particularly if it's someone with some experience in the field, to sort of not have them kind of explain to me what someone just said, but I'd like to hear what someone just said, But, so I didn't realize there was a telephone, and that certainly must set a number of people a little bit back.
Yeah, it does, oftentimes, yeah.
Okay. So let's go back now to some of the other cultural barriers that you were starting to reference.
Well, I think, that the telephone, that the translation, that they may be like a physical barriers that the person will be exposed once the person is reached the mental health clinician. But I think to be able to reach the mental health clinician at any point, it's very difficult. And I think that's one of the biggest barriers. We know that the majority of I'm more familiar with the Hispanic-speaking patients, of course, that they do have, in different cultural values, that it tells them it's not cool to go and see a psychiatrist. It's not cool to go and see a therapist, especially for the male gender. Nothing against it. It just happened to be a factor of life, a factor of the cultural life. And once they have made up their mind about going, then they have to overcome several different psychological issues. For example, how about my neighbor? But now I'm in a different culture. It's okay for me to go and see it. Okay, now where do I find it? It is very difficult to find it once you have made your mind that it's okay to do it, and that the neighbor is going to be okay with that, and maybe you shouldn't tell the neighbor. And it's okay for a man to go and receive this type of, counseling. Where do you go back? Try to look for the yellow pages. It's very difficult. There are not that many Spanish yellow pages, and there are not that many minority, yellow pages as such. Well, let's assume that you find that there is one. There is, the Chelsea group. There is Alianza, Alianza Hispana is a big group. It has been for many, many years. I just happen to be working there with them too. And, once they get to the point of going there, are they going to be able to speak my language? And once they go there, am I feeling okay here? Is this a place in which my culture is seen as okay? So So there are different factors and different barriers that the person go through it, and some of them, by the time that they get to be seen, by the time that I see them there, had difficulties rather advanced. Different disorders that we normally would have seen it before. Depression is really at times very well advanced at the time in which, could have been seen much, much earlier. There's a delay in the process of access. So access to mental health, access to the clinicians is very crucial. Fair number, of clinicians, the Spanish-speaking clinicians, or persons who are sensitive to this are very small. That there probably are about 10 psychiatrists, Spanish-speaking psychiatrists in Massachusetts, where is the biggest concentration of psychiatrists in the world. We only have about 10 Spanish-speaking psychiatrists. It is a lot, and I know that there's a lot of persons who are very interested, and they're becoming more sensitized, and that's what I agreed to this program, because it does produce like a call for to be more sensitized to cultural needs. As you're working with the, different other cultures and different minorities, which it becomes like a must for all of us who like the cross-cultural psychiatry, cross-cultural mental health issues.
Now, Diane, you're a woman. Do you find men sometimes, Hispanic men, have trouble relating to you because you're a woman? We'll move beyond the language now. Because you speak fluent Spanish, I understand. So, how do men relate to you?
A little bit more difficult than the females do, although, as Dr. Veliz was talking about, once we get to that point where they are willing to come and receive the treatment, they eventually catch up to where I usually am with the
But
women.
now he was suggesting, and perhaps this is your experience too, that because of the stigma and because of some of the cultural barriers, it takes a bigger problem to motivate, especially, say, an Hispanic man to ask for help than it might take someone from a different culture.
I agree with that. I think what you were talking about earlier was, I think you had said that they oftentimes will say, oh, I'm fine. And, I think I myself have to make more of an effort to really allow myself to let them know that I do care and that I am trying to be available for them. And so it is a little extra work on my part, but I think once we get there, it's able to move more smoothly, but it isn't always so easy. And yeah, I think it does have to present itself much larger than somebody else who would be more willing to go and receive treatment.
Okay, now let's switch to women, because I understand you see a number of women. What are some of their problems in relating to you? Where they speak Spanish, you speak Spanish, they're women, you're women, you're a woman. What are some of their difficulties, would you say? Or have you identified any patterns that...
with working with me?
With women. Yeah.
I would have to say depression primarily. I know that one of the things that has been happening pretty frequently is, I had mentioned about the medical piece, that oftentimes they get misunderstood. I know Dr. Veliz and I have encountered that a lot frequently, that they're being labeled as something medical is going on, and the reality is that they're not being understood by whoever it is that's examining them. So everyone's thinking that they're, complaining or there's nothing really wrong. And then when Dr. Veliz or myself will talk to them, in fact, there is something greater going on, maybe some depression that was overlooked, that was being seen as, somebody who was needy but in fact it was something mental health related that otherwise would have been overlooked, I think.
As a matter of fact, that was 2 cases that we just happened to share, and that was very interesting cases, because the 2 of them had been referred to us as there is something strange here. They have had a lot of somatic complaints. The person had a lot of aches and pains, and the pain.
Now, is that common to somatize a lot of psychiatric problems?
I don't know if it's really more common than, let's say, generalized anxiety disorders. I think the disorder is one, but because of the cultural values and the cultural itself, the person's manifestations of a disorder, it can be different. And I think that's what we were seeing, in which the person was having these, disorders that felt that it came from the top of the head all the way down, that it was moving from left to right, that it was shaking to the right. And then the medical doctor who have seen it said, wait a minute, this is something strange here, we've never seen this. And when you come to talk to her and we discuss with her, we come to terms, she felt very sympathetic, because it was the first time that she was able to talk in Spanish. And it came out to be a very clear case of depression. Once the person was treated with the proper medications and the proper psychotherapy, the person came out of that and they was able to move on like anybody else. The second case was of a person who was really suffering from an acute disorder of the left shoulder. And the person couldn't move the shoulder. And it was, in my mind, in our mind, after reviewing the case over and over, it was a clear depression case. That person was not really seeing it as such, because some of the manifestations, it may be different. And there is the sensitivity to the culture. Each culture presents very differently a certain degree of depression. Although the depression is the same, I believe that the disorder is practically the same because of how we are trained early in life, because of how we are exposed to different things. Then the representation of the disorder, specifically depression, it tends to be shaped up differently. And I think that one of the calls that we're making is the fact that if we can be just sensitive to that, I'm not saying that we become, from another culture, or we all need to learn all, 256 languages that exist or more. No, I think the sensitivity to that, to be sensible, to be sensitive to that, and to know that there is certain different cultural values that represents differently.
Okay, well, maybe Diane, in the last minute before the break, can you give an example of that, where a cultural difference, in other words, what do I need to be aware of? Because I don't speak Spanish and I'm not Hispanic. But let's say I'm evaluating someone who is.
I think that the sensitivity piece is critical in terms of hearing them out, hearing what they have to say. Don't minimize it as something else, but because I think that what happens often is once, we run into them on some level and they're talking to us, just the fact that we aren't kind of brushing them aside and saying that or calling it something else, but just that we're able to sit with them and hear them out as best as we can, I think is really critical for anyone who's working, even through an interpreter if that's how it needs to be. But I think that that's the first step, very important.
But are you suggesting that maybe where there's a language barrier, as the evaluating psychiatrist in this case, I might be a little impatient, or I might be in a rush, or I might get a little frustrated by some of the language issues and kind of...
I would say probably more frustrated, just because I'd imagine it's often difficult. I know it would be for me with somebody who didn't speak Spanish or English, the frustration of not really maybe getting it and feeling like you are missing something and wanting to help desperately, but not knowing how because of the language barrier.
Okay, well, we'll take a break, and maybe after the break we could look at some areas where these barriers are overcome and services are being well provided, and then juxtapose that to situations where they're not so well. So we'll take a break at this point. Thank you.
As America has changed, Social Security has changed. A foundation of monthly income for retired workers was created in 1935. Then changes were made to provide for widows and widowers, and for disabled workers and their families. Later still, changes were made to ensure that benefit payments would always keep up with inflation. Now Social Security will need to change to provide for the retirement of 76 million baby boomers early in the next century. It's a big job, and it needs to be done right, so that Social Security will continue to help support not only the baby boomers, but their children and grandchildren as well. You can help draft the blueprints for the coming change by learning about the issues involved and our options. For more information, call 1-800-772-1213 and ask for the booklet, The Future of Social Security.
60 seconds, Miss Moreno.
Thanks. Hi. As an actress, I've played so many roles, from a teenager in a New York barrio to a nun at a prison. But today, I have an important new role as spokesperson for the United States Treasury Department. Today, I'm telling you about a recent federal law which encourages millions of Americans to choose a simple, safe, secure way to receive federal payments and benefits by direct deposit. With direct deposit, your federal payment is deposited into your checking or savings account automatically. So you'll never have to worry about your check getting lost or stolen, and you'll no longer have to make special trips or wait in line to cash or deposit your federal payment check. Sign up for direct deposit at any bank, savings and loan, or credit union.
5 seconds, Miss Moreno.
Just enough time to say get direct deposit. It's simple, safe, and secure.
And let's maybe talk a little bit about when services are being well provided for people from, say, an Hispanic culture. Where do you see it working well, and what are the factors, the ingredients? What's the formula that say makes it work well? Thoughts?
Well, I think my experience has been that the more sensitive, the more knowledgeable, and the more acceptable that we are of a, diverse culture, that probably is the best recipe in order to work. That it's not necessarily that the person talk the same language, but it's necessary that the person becomes sensitive to the cultural values of the other person, and that allows them room to kind of not follow the normal pattern that we are accustomed in something that we have learned. And some of those cultures may present a new, different set of symptoms that we just probably never exposed to them, and that therefore just allow them room to be present, to exist, those symptoms, and then pay attention, that we can also learn from them. That's one. And that could work on the local level, let's say, on the individual. As a group, I mentioned to you about the 810 psychiatrists that we had mentioned, the Spanish-speaking group that now for about 2 years, close to 2 years, we have met, and we've been thinking about what would be exactly these kind of questions. What do we have in Massachusetts? We do have a population close to 23% at times of a Spanish-speaking population. What can we provide as a group, as psychiatrists? What would be our responsibility? Is it time to make a inpatient psychiatric hospital? If you are a Spanish-speaking person and you become psychotic for X, Y, or Z reason, it's very difficult to go to an inside psychiatric facility and just expect to be seen in Spanish. It doesn't exist anyone. How do we deal with them? How do we the 8 of 10 of us, and we wanted to expand this, and we are in the process of think tank. We are in the process of thinking about this and modular a modular future for the next century about the Hispanic culture in Massachusetts. And we want to expand to psychologists, social workers that think about what would be the best possible way. I know, for example, I mentioned before about the Alianza Hispana, which is a group that have existed for many, many years, and their model is to have a complete Spanish-speaking approach to the person. The patient comes in, he gets seen by the social workers, by the clinicians, psychiatrists, and everything is done in Spanish, and it does work beautifully. Although all the records have to be written in English and translated for DSM-4 in order for the economics to take place. Is that one of the best ways to do it? We don't have a central place in which we can say the majority of inpatient psychiatric hospitalizations can be done in X, Y, and Z place. We don't have it. Mm-hmm. So I don't have the answers.
Do we have situations where a Spanish patient might go to a facility where there's no Spanish speaking?
Oh, sure.
Really?
Oh, sure. I mean, and it's devastating. The patients have told me clearly, when I got there, the patient was psychotic. And how to communicate Not being psychotic is so difficult. Now, when you are psychotic, it becomes close to impossible. And the person who is trying to make sense around you, you become in a world of no world.
I'm just curious, the 23% you're referencing, what percent of those speak English, would you, any thought?
That is very difficult to say. I don't think I have the clear statistics of that. I believe that there is a certain percentage that will only communicate in Spanish. And of course, that's as a matter of time. You know, the person gets scared, get acclimated to the whole system, start learning the language, and that's something very peculiar, you know, and Diane can also elaborate on that. The fact that, say you meet somebody who is bilingual, and you talk to them, and at the beginning it starts Spanish. And something funny happened, that when the person, in my experience, has been that when don't want to deal specific issues, they shift the language. And very quickly you end up talking in English. And then when it's certain issues that they belong to them especially, they switch back to Spanish. Has that been your experience, Diane? I mean, that is so intriguing just to see it, you know.
So, but if they're bilingual and I'm not, then they can kind of include me or exclude me.
That would be the counterpart, you know. And I hope that it will not be seen as a negative on the patient side, because I think it's more as you know, when can the person can communicate better their thoughts, either in English or Spanish? You know, when can the person feels more comfortable? Issues about childhood years, more than likely they will be communicated in Spanish. Things that belong more specifically to them, they'll shift to that language. Or things like had to do with specific accidents, you know, specific incidents, the words will come up in Spanish immediately. That would be the first like a line of thought that the person will have. You know, and it's not disrespectful that the person will shift to the language, but it's as a matter of better communicate into it. Yeah.
I just wanted to comment and add to what Dr. Veliz was saying about the sensitivity piece, and I feel very fortunate that I get to work so closely with him, because it's always an ongoing learning experience for myself. I'm always getting something from Dr. Veliz that I think I would have otherwise never have known, and we're able to work together with our team on those things. So even though, you know, they may not speak Spanish necessarily, they are going to be aware when they do come across a Spanish-speaking, for example, patient who they will be working with, and they'll have that extra knowledge. So it's not like, you know, just because I speak Spanish, I know all of these things. It's an ongoing process that, you know, we're able to share with everyone, hopefully, and it's you know, we're able to learn all the time. You know, catch things that we would have otherwise missed. So,
of course, I mean, we could generalize it. I mean, men might have the same problem treating women, or Jews treating Catholics, or you know what I mean. There are likely to be problems encountered. Maybe obviously the language barrier is one. It's an entirely different order of magnitude, you know, kind of problem. But I think. I mean, can sensitivity be taught? I mean, can someone like myself learn how to engage?
Definitely. I think I mentioned before, and we probably mentioned, you know, at the beginning of the program, and probably didn't give enough of time of importance with the fact that what Diana did. You know, it's a beautiful experience. The fact of, you know, being able to just decide to go on herself, to go to another culture, and to be exposed of what somebody would come from there to here. She went to Mexico, and in a period of 6 weeks, she engaged herself in a full-time study of the language. And of course, she had some previous knowledge of the language. And then when she came back, it was just beautiful to be able to see how she was able to express and communicate with the patients. It was just marvelous. Now, we may not have to have the whole extreme, and maybe not have the whole, you know, kind of courage to do all of that, but at least to have some extra sensitivity to the language, as I believe that the person who comes to this culture has the obligation to learn and amalgamate about the cultural values of what we see here. Then we, the persons who are here, who have felt more familiar with the culture, also had to become more sensitive to the cultural values.
But can I do that? I mean, I'm a young man, but I doubt very much I'll ever learn to speak Spanish. I could never learn to speak French, and my French teacher died, or I would have flunked the course, I'm sure. So short of having to learn the language, can I learn or any number of us clinicians interested in being better at what we do, can we learn how to be effective therapists working, say, with Hispanic patients, even though we aren't able to master the language?
I believe so. I think I'm thinking about specifically my trip. I had gone with other clinicians and who didn't have any knowledge of the language, but just the whole experience of being around it and being aware of what it is like to go into another country and not know the language and what they are probably faced with when they come here, whatever the language may be. I think you can't help but gain a certain sense of sensitivity. And I don't think it has to be in another country. I just think, so yeah, I do think that it is something that could be learned. Yeah,
you know, I think it's small details, you know, like for years, we don't say, you know, how many years, you know, you have called me Jorge all the time. And that's a beautiful way. You know, I never told you how nice I felt about that, because the majority of the people who know me by George. Now, I don't remember my name to be George, and I always felt very positive towards you, the fact that you would call me Jorge, because it was a way for respect the cultural values. It was a way to be sensitive to somebody else's. I believe that one word can get us to go miles into the inner psyche of a person to be able to relate to the therapist.
But you don't then point out to people that your name is Jorge.
That may be cultural, you know, and the fact that one does not, you know, bring up themselves to say, hey, wait a minute, my name is not George. You know, you have to call me Jorge. Immediately, I've been putting a barrier, or I am thinking that I'm putting a barrier when I don't want to become Americanized by the name of George, when here is the name George. And it's something peculiar, and it works in both ways. But one certainly does respect and becomes very sensitive to the fact that somebody would recognize you for that name.
Well, I had the mini experience like that. I was invited to speak to a group of internists so that they could get to know our South Boston program. And when they sent the notice around, they had misspelled my name. So I had to quickly decide, because this was a brochure, would I point it out to them or not point it out to them? And I felt very petty in making a call to say, hey, you spelled my name wrong, because I really didn't care, except that this is all by way of introduction, so they'll know about our South Boston program, and I won't tell you what I did. So what are some of the other...
well, there are some courses, and you know, they're giving out there, you know. In those courses, sometimes I you know, have talk about, you know, with other clinicians, Spanish-speaking clinicians, how do they do when they make a presentation about this? And it is not always possible to find like a complete details of all the cultural values that one would have to learn and to be assertive about and to be able to become a sensitized therapist. But I think the core value of them is the fact of really getting to know a little bit more about the culture and don't be afraid of that, you know. And I think if we do make a conscious effort of that, we have gone about 90% of the effort that we need to. Then the other cultural settings, you know, like respectful to what the person is saying, but all those are the same. I think it's the same process, except to be allowed room to be able to hear the differences in which they present the signs and symptoms, and then to be able to react to that.
Okay. Well, we'll take a break, and then we'll come back and maybe talk about some of the special issues in treating Hispanic patients.
If you give me a fish...
Give a man a fish.
If you give someone a fish,
you feed them for a day. A day.
One day.
If you give someone a fish, you feed them for a day. But if you teach a man to fish...
Teach me to fish.
Teach someone to fish.
And you feed me for a lifetime. A lifetime.
My whole life.
If you teach someone to fish, you feed them for a lifetime.
Give me a fish, and you'll feed me for a day. Teach me to fish, and you'll feed me for a lifetime.
Through Volunteers of America, you can help change lives in your community. Find out what you can do. Give us a call.
Welcome an exchange student into your family. Learn about another culture in a fun and exciting way with Youth for Understanding International Exchange.
I'm finding myself wanting to learn more and more about other countries, and it's really interesting.
I love learning new things and sharing my cultures.
These students bring something to the school that doesn't come from books.
While your exchange student brings their world and customs into your lives, you get to share our great country with them.
I guess I only thought you could love your own, but it's just been a great experience for all of us.
Go global. Call 1-800-TEENAGE for this free booklet. Learn how you can welcome a Youth for Understanding exchange student into your community.
We've learned so much, and very close friends of ours have now decided to host also.
So some of the special issues in treatment of Hispanic patients, some thoughts, what they might be?
Well, one of the first that come to my mind is, you know, usually when a person says something, you really have to go around and have the deeper meaning of that. It is very well known that in the Spanish language, being a romantic language, the person will say many different words, and you know, you really have to look for deeper behind the meaning. It's not always like the exact word associated with the feeling to that. And that I have just picked up through years of experience, which is, you know, the person will try to explain different things, and probably I'm doing the same in English, that as you go around, you try to say something, and you do say something, but it's the meaning behind that it had to be kind of looked at it. That the person, it is, and they talk about this thing, that it is a difference between the so-called white system and the Hispanic system. That there is a system in which, you know, the words count for every word that you said. Well, in Spanish, you may say 50 words and you meant 10. And that it plays out a very special role in the psychotherapy issue. And it plays so many things, so many times, you know, in for example, a patient may say, you know, and I said that I wanted to kill that person. And really didn't mean that. It wasn't just in the passion of the moment to say this thing. Said that to my wife, and my wife said that to me, and I really doesn't have that meaning to it. I said that about the government, and really doesn't have that meaning to it. And when you come to explore, and you said, you know, it is more than likely than not that the person really didn't mean to. And it was part of the, you know, way of expressing one's language. And of course, this is taking it to the extreme. And if you take that to be the extreme, you would expect that there will be so many other words that they would say in the moment of a conversation and in the heat of a conversation, that it really doesn't carry that amount of power that you would carry on the other system. You know?
But then, again, I mean, a lot of men, say white men, will say, I didn't mean it, you know, if they've been arrested on a 209A violation. So, but you're saying that it's not just a manipulation, that they really might use a richer language to express themselves and don't necessarily mean what the content might allow.
I mean, in my view, cultural to me is like the values that one has learned early in life. And if the person has been exposed to this way of saying things, and we give you, for example, you know, let's say that we were born and we are in a place in which we don't wear glasses. Nobody wears glasses. All of a sudden, you are transported to a place in which everybody wears glasses. So the criteria in which you are going to be judged is very different. You see things very differently once you put the glasses on it. But if you go back to a place in which there is no need for glasses, that is acceptable too. You don't have to see 20/20. That's an arbitrary measure. Well, very similar to the cultural values. If the cultural values of one culture has been set to a certain standard, and then it's passed on to another culture, and it's kind of based on different standards. It's required to be processed in a different level.
Can you give an
It will
example?
appear to be differently. Well, like I was saying, that was one of the ones that, without glasses, you could say all of these things and the person would not be judged as that. If you go to a culture and all of a sudden you are saying these things, you are going to be judged based on as if you would have glasses, meaning that, well, you can't say that here. Let me give you an example, more specific. Somebody was detained and it was sent to local jail, and the person wrote a letter, and it was in Spanish because he only knew Spanish, and then he gave it to somebody else to translate it because he wanted to say how sorry he was for whatever he had done. The other person supposed to translate this letter, well, the letter got lost. So this person became very upset to the chief commander or to the person who was in charge of that jail. He went to that person and said, where's my letter? What letter? He said. I don't know. What are you talking about? He said, yeah, you must have that letter. I gave it to somebody, and everything that belongs here, you are responsible for. And I want to talk to your superior. Well, that didn't go that well. And as I explained to him, being in a system in which he has to learn different set of values, he probably was accustomed to talk to his superior and to the superior of the person right away and to get some answers. In that system, he was doing the inappropriate things based on the cultural values. Once he was retrained, he understood what the difficulties had been to him, and then he was able to change.
Well, he was able to learn how to survive in a system that may not be proper.
And that, whether it's proper or not, is the cultural existence, the presence. Like I said, if you are in a world in which you are judged by, the 2020 of the classes, that's how it's going to be judged. So I believe that both sides have to be more sensitive to each other, in which one group has to be more sensitive to the cultural values, and the other person also has to be sensitive to the other culture's values, because you cannot expect to be, isolated in this world and expect to have the same values that you have without having an understanding of the values around yourself.
Now, in the same vein, medication, is that a particular problem for, say, Hispanics as opposed to non-Hispanics? I'm talking about not just the dosaging, which if you have some thoughts about that, but just the whole phenomena of I prescribe, do you take?
Sure, Diane probably will, have the same experience.
Yeah.
And if I ask a Spanish person, I probably shouldn't say this, but if I ask a Spanish person, what medication are you taking? They'll tell you, it's a white pill. Do you take any other one? Yeah, another red one. But what's the name? Okay, then finally come out the name. Okay, how about the milligrams? You could forget it. It's a white pill, and that's the name of it. And it tells you exactly what it's written in it, but forget about the dosage. Of course, it's a generalization, but it's more frequent than not. And so when the person comes into a place, either they bring their own, all the cards with all the medications, and it's not very common, when I see them and they have a bag full of medications, but they do not remember the medications. And I believe that had to do with the, cultural belief that the doctor is able to know exactly what it is that they need to prescribe, so you don't need to challenge that.
Do you have some non-compliance? Do you have people who just sort of, I don't know, for cultural reasons decide that it's too insulting to take a pill?
That really hasn't been my experience any more than the rest. I mean, I think it happens as much as it would with somebody who isn't Hispanic or from another culture, but yeah, I do see that a lot. They really count on you to know what it is that they're taking. Yeah.
In response to medication, are there some cultural differences?
Well, there's been some studies done, and the fact that yes, certain dosages, it's recommended that because of the way that it's metabolized with the P450, it does appear to be a difference in the way that they metabolize, or certain cultures metabolize certain. And there is some studies, although I don't recall exactly the specific studies. I know for a fact that I usually use less dosages of patients in my Hispanic patients. They are, they respond well to those. And also the notion of the dosage, although I see that in other cultures too. Like sometimes the higher the dosage, the better, therefore they should respond better. They should have a better response because, let's say, 700 milligrams as compared to 1 milligram. There's certain kind of intrinsic value in that. Technically and clinically, I see better response when the person Hispanic nature to have in lower dosages. That it's just been my experience.
And response, though, when you achieve an adequate dose, is as good, about the same, better, worse?
I think it's about the same. I mean, the response is usually about the same, and the person feels like he's responding very well. I think it's very well accepted, those medications, and they feel very comfortable, with the dosage. Yeah.
Okay. Do you have many men who just say, it's only for wimps?
My experience has been that there aren't, it seems like there are more women on meds than the men.
Right. There are maybe not a great percent, but more women than men who are likely to just on general principles say no medication, my body is a temple kind of thing. Okay. Any other special issues in the treatment? We only have a couple minutes left.
I think, again, just to bring up what we were talking about earlier in terms of, taking time to sit with them and not feel so rushed or frustrated and really be able to hear them out, I think is really important.
I remember a number of years ago we argued, you and me and others, about this man from a totally different culture, about whether his food habits were cultural or driven by psychosis. And we watched this poor fellow really lose weight day in and day out as we struggled to figure out, because we wanted to be sensitive to the cultural issues. And I remember one day with Jorge's permission, basically saying, look, I know there are a lot of cultural issues here, but this man is psychotic. We got a court order to force medicate him, and he flourished after that. So I guess that was an example of kind of where we were going overboard in delaying appropriate treatment, a little bit concerned that perhaps we would be insensitive to his cultural norms, because he was from a very different, not Hispanic, very different culture.
And I think, like to make emphasis with what Diana said, the sensitivity to it, or like you said, it's difficult to learn different languages. I do believe that that's the case. It is quite effort that one has to put it into it, and you have to like the culture, you have to like all of the system. But I think, like a very good professor of mine, used to say, he used to travel and give different conferences at different places, and every time that he would go, and let's say go to France or go to any of the other places, he would make a point to learn one or two words of that language. And I believe that if we can even do that, every time that we see a patient, and we can learn of different culture, if we can learn one word or the other one, that word can bring us so much closer to that person. Because, it is a very well-known fact. If you said one word, the person does not know how much you don't know, but you know that that's the beginning of it, and enters a complete, closeness to that person. It's very
it conveys. When we went to Italy, we got the same suggestion.
Yeah.
Try to learn a few words so that we wouldn't come across as arrogant Americans who expected them to speak English and not expecting anything, from ourselves. But we do have to stop. I really appreciate both of you taking the time to be here today. I think just talking about the subject helps a lot, I think, to become more aware of some of the special issues. So on behalf of the Norfolk Alliance for the Mentally Ill, thank you very much for being here. Very much appreciated.
Thank you.
Thank you for allowing us to be here. It was a pleasure, and we wish you the best in your program, indeed.
Thank you.
Thank you.
Thank you.